Hi everyone, welcome to Hub Bites. I'm Sanil Rege, consultant psychiatrist. If you're new to this channel, we cover all things psychiatry and mental health related. So if that's your thing, then don't forget to subscribe and also hit the notification button so that when we come out with a new video, you're informed straight away. So what we're going to cover today is obsessive compulsive disorder. Now, in sort of our lay language, we've had the term OCD, you're OCD. If people are meticulous, do things in a particular way, we often tend to sort of callously or loosely use the term OCD. However, obsessive compulsive disorder is actually a really serious mental illness, and as you'll see, really ranks amongst the top disability disorders amongst all disorders, not just psychiatry, but other medical disorders as well. So it's a really important disorder. And what we'll be looking at today is how to diagnose it and what are the main treatment principles. So without further ado, let's jump into what is obsessive compulsive disorder. So OCD is a mental illness that causes repeated unwanted thoughts, and that's the obsessions. Now, these can be thoughts or sensations or other sort of images even that can occur. Or the urge to do something over and over again, which is compulsions. So OCD, obsessions and compulsions together. But not all patients tend to have obsessions and compulsions together. Sometimes it can just be obsessions without the compulsion. So instead of the obsession, the neutralization can happen through another thought instead of an actual act that an individual is carrying out. The lifetime prevalence of OCD is believed to be between 1% and 3%, and patients can experience chronic or episodic OCD symptoms throughout their lifetime. So sometimes it may subside, the OCD, and during stressful situations, the symptoms can come back really strongly. As we often talk about, disorder is really characterized by the impact. So an individual can have a range of symptoms without having any impact on their life, in which case it's not a psychiatric disorder. Treatment might not be required because they're coping okay with it. It's only when it starts impacting their life significantly across a range of domains that we call it a disorder. So OCD is a time-consuming and distressing mental state that has higher disability-adjusted life years. It's a way of sort of getting an estimate of the disability of the disorder than Parkinson's disease and multiple sclerosis combined, making OCD one of the top 10 most disabling medical conditions. So what are the types of obsessions and compulsions? Essentially, we'll look at the criteria, but obsessions are they can be thoughts, for example, images, etc., but they result in a lot of distress. And the individual then neutralizes this distress by carrying out a compulsion. So that's the basic principle behind it. Now, what are the kinds of obsessions? We can see there's fear of contamination, there's pathological doubt. This can result in a lot of procrastination and a lot of time being spent in making a decision even. So the individual can be paralyzed and therefore might not be able to make a decision at all. Sexual or violent intrusive thoughts, fear of causing harm, need for symmetry and exactness, religious obsessions, and superstitious obsessions. Now, one of the characteristics of obsessions and how to differentiate obsessions from other thoughts such as preoccupations or from ruminations, these are different thought categories. Obsessions tend to be what we call ego dystonic, which means that they aren't necessarily congruent with what the person's feeling. So they're ego dystonic, which means that the individuals often recognize them as senseless. So many patients will often say, doctor, I know that it's completely senseless, but I can't understand why they keep coming into my mind over and over again. So that's the characteristic. Whilst with the rumination, which is more likely to occur in, say, depression. I've done a video on melancholic depression, so do have a listen. That's where you get these really prominent ruminations and overvalued ideations. They are egosyntonic, which means that individuals feeling terrible and they have thoughts such as obsessional guilt, where they're saying, I know I'm a bad person because I've done X, Y, Z, which is a rumination or overvalued ideation. So obsessions tend to be ego dystonic. Then when we look at compulsions, Now, the individual will generally fear contamination neutralized by cleaning or washing rituals. Pathological doubt, repetitive checking. So pathological doubt, I've made a mistake, so I need to keep checking it over and over again just to make sure that I've done it correctly. So say, for example, a patient who's a nurse, for example, has this really pathological doubt that they're making a mistake, or say giving medication. So repeated checking, which means that work can be very, very stressful because a lot of time goes in administering medication to one patient, for example. Then we have, say, sexual, violent, intrusive thoughts. Repetitive, undoing thoughts may occur rather than an actual compulsion. Then fear of causing harm, repetitive checking again. People check doorknobs, for example, whether the door is locked, for example, whether the child's in the back seat. So many different things come up with OCD. Then we have, if there's symmetry and exactness, then ordering or arranging things. So sometimes even small changes, so say for example paintings just sort of moved this way, the individual can get extremely distressed and has to get it straight. Now, many of us might have a spectrum where small things bother us and we correct them, which is fine, but in OCD we're talking about really severe intrusion of these obsessions and compulsions. So that's important. It's not just once off. Then we have religious obsessions, so religious rituals, excessive praying might occur. Superstitious obsessions, where you get superstitious rituals, for example, repeating activities a number of times. So these are the types of obsessions and compulsions. What are the risk factors? We have family history tends to be a prominent risk factor. Then physical differences in certain parts of the brain. And this is really the neurodevelopmental aspect. What that means is from a neurobiological point of view related to the OCD, you can, of course, go to psychscenehub.com where I've written all of this in detail. But essentially, there is the brake system of the brain, which involves sort of the cortical, frontal cortex, involves the basal ganglia, involves the thalamus, involves what's called the striatum. And this is the loop that actually has puts a brake on these unwanted thoughts. In obsessive compulsive disorder, this brake is faulty. Then we have depression, anxiety, or tics. So when there's comorbidity, these go hand in hand. There's an increased risk again. Experience with trauma, of course, and a history of physical or sexual abuse as a child are also risk factors. Now, how is obsessive compulsive disorder diagnosed? An OCD diagnosis is based on clinical assessments of obsessive thoughts or compulsive behaviors that last more than 1 hour a day and are not the result of a medical condition or substance use. Patients also do not have to show both obsessive and compulsive traits to be diagnosed with OCD. Now, the DSM specifies OCD symptoms as clinically separate from delusions or persistent negative thoughts that may be associated with other psychiatric disorders such as depression or generalized anxiety. As I mentioned, their separate obsessions tend to be ego dystonic. So what are the DSM criteria? We have presence of obsessions, compulsions, or both. Obsessions are defined as recurrent, persistent thoughts, urges, images that are experienced as intrusive and unwanted that in most individuals cause marked anxiety or distress. Then the individual attempts to ignore or suppress such thoughts, urges, or images, or to neutralize them with some other thought or action, which is really the neutralization. Now, there are certain psychodynamic mechanisms that they talk about, such as magical doing and undoing. So in this doing and undoing, if I have this thought that I've just now touched something dirty, I'm going to transfer those germs to my child and the child's going to get harmed. So there's a thought of harm, and therefore there will be a neutralizing thought. If I do this, which goes into the compulsion, that will prevent harm from occurring. So compulsions, they are repetitive behaviors or mental acts. Now, it could be thoughts as well, mental acts, such as counting, for example. Some patients do that the individual feels driven to perform in response to an obsession. The behaviors or mental acts are aimed at preventing some dreaded event or situation, but are not connected in a realistic way with what they are designed to neutralize or prevent. So that's why the ego dystonic people might often describe it, doctor, I know this is senseless, but I can't stop those thoughts and I have to do this. Otherwise, I'm really anxious that something bad's going to happen. The obsessions and compulsions are time consuming and cause clinically significant distress or impairment in the social, occupational, or other important areas of functioning. So, how is obsessive compulsive disorder treated? Now, the key principles are we have medication, we have psychotherapy, and some alternative treatments are also present, showing more evidence nowadays. But firstly, psychotherapy is crucial. Now, this is one of the disorders where evidence shows that both psychotherapy and a specific kind of psychotherapy, along with medication, tends to have better results than one or the other on its own. Now, when it comes to psychotherapy, the type of therapy is cognitive behavioral therapy, but there is a specific kind of cognitive behavioral therapy, mainly moving towards the behavioral aspect, that it plays a very important part here. And therefore, when a patient is referred for OCD, it is important that the psychologist has a good skill set in this particular kind of therapy. Otherwise, it's not just counseling, it's not just mindfulness or emotional regulation. It is specific, and it is known as exposure and response prevention, ERP. Your doctor will put you in a situation designed to create anxiety. So this is the exposure. And what happens is when the individual is exposed, they have a huge amount of anxiety, naturally, because it's a feared situation. That anxiety rises. And one of the important things with this is the concept of habituation and extinction, which means that when the individual is in that situation, we know that anxiety doesn't keep rising forever. It will always reach a peak, plateau, and extinguish or become extinct. That's known as habituation and extinction. Now, what we want to do in OCD is we want to have this process occur naturally, rather than where the anxiety goes up, the individual carries that compulsion, the anxiety goes down. So you end up with this, which is not helpful. So what the therapist will do is exposure, anxiety goes up, the individual will be asked to prevent, response prevention, prevent that response so the anxiety habituates and becomes extinct. So that's the principle. ERP is the evidence-based treatment. Now, if compulsion is in there, techniques such as thought stopping are utilized. So through that, one gets better control over these thoughts and actions. Next, medication. Now here, two important things. First line medication are what we call selective serotonin reuptake inhibitors. We've covered a video on this, so do have a listen. But when SSRIs are prescribed, higher doses are required than for anxiety or depression. So the maximum doses are often required. Now, this is, of course, something you will discuss with the treating doctor, but we're talking higher end of the spectrum of doses are required. And usually, agents that are used are citalopram, escitalopram, of course, a range of other sertraline, paroxetine, etc. can be used, but generally the most serotonergic citalopram, escitalopram are the ones that are used in clinical practice at higher doses. Now, of course, with SSRIs, risk-benefit analysis needs to be carried out. They come with their own side effects, ones that I've touched on in the other video. But this is a risk-benefit analysis between treating the disorder and managing the side effects of SSRIs. If patients don't respond, there is the other medication, which is clomipramine, which is a tricyclic antidepressant, which is for treatment resistance, that can also be utilized. Again, side effects can occur. The other important thing is that unlike depression and anxiety, OCD takes longer to respond, up to 12 weeks. In some cases, go up to 16 weeks even. So that is the other thing. Higher doses, longer duration is required. Now, in some cases, as you can see, augmentation with antipsychotics is an augmentation strategy in resistant cases and can work. Low doses are often required. Other agents such as N-acetylcysteine, lamotrigine are also evidence-based in OCD. Now, some other antidepressants that can be useful are agomelatine, which is by the trade name valdoxan, but agomelatine is a useful agent in OCD. There are a number of studies that show its benefits, so those can also be considered. And then when we think about neuromodulation therapies, this is for really resistant, refractory OCD. Now, we have neurosurgery, specific parts of the brain, stereotactic, so connections may be disrupted to prevent that faulty break in a way. Deep brain stimulation and repetitive transcranial magnetic stimulation as well are evidence-based. In fact, DBS is showing a really promising tool in management of resistant OCD. And RTMS is again, Very minimal side effects, evidence-based in OCD as well. But a different part of the brain is stimulated as compared to depression. Again, we've got a number of videos on TMS where I've interviewed experts on this channel. So you might find that helpful. So with that, thank you so much for watching. I really appreciate it. If you do have other topics you'd like me to cover, please let me know. I'd love to do some more videos that, you know, help you understand psychiatric disorders and mental health disorders in more detail. And of course, don't forget, if you liked it, don't forget to leave us a like. And I look forward to seeing you in another edition of Hub Bites. Take care and see you next time. Bye-bye.